Hello everyone, this is Chadi Alraies from CVI 2022 in Denver, Colorado. I'm really privileged today to be with my friend and colleague, Anand Prasad. He's from UT San Antonio. Anand, thanks for being with us.
No, thank you so much.
Yeah, you've been an expert in low contrast, AKI complication post-PCI, and how we minimize the contrast in the cath lab. But now you did a phenomenal session about CTO and low dose contrast.
Right, so I mean, first of all, it's great that this topic is even coming up now, that we're focusing on the kidneys. As we do all these complex interventions, CTOs and Impella-supported PCI and shock, STEMI, we're now thinking about the kidney health, and I think that's really important. So really what I talked about in my session was how can we better align our procedure with thinking about end organ perfusion. So looking at hypoperfusion and hypovolemia, correcting that. If a patient is hemodynamically unstable, hypotensive, correcting hypotension, and really avoiding bleeding. Bleeding, we know, is linked to bad kidney and overall patient outcomes. So thinking about things like radial approach, being judicious with our antiplatelets, anticoagulants, single access approach if we're going to use Impella-supported PCI. So all of these factors are important. And then really minimizing our contrast use, just being judicious about our injections and using common sense methods to reduce that, avoiding excessive puffs, using automated injectors or divert type technology to prevent excessive contrast dosing.
So how about in terms of teaching the cath lab staff, and how about this protocol as well? Is something requires some teaching and some policy to be distributed, or this is case by case?
So I think you have to have a uniform policy of how you approach these patients. So at timeout, talk about their eGFR, calculate that using ideally a CKD epi formula, which is available online. So you get their eGFR, and then setting a contrast limit for that patient. For many labs, that may be 2 times their eGFR. For us, we use 3 times eGFR. And then monitoring your use during the case to see where you are relative to that limit. So that's got to be regimented. It's got to be part of the timeout. It's got to be part of the morning board rounds. Coupling that with a protocol for volume expansion. So majority of patients coming to the cath lab who are either euvolemic or hypovolemic should get volume expansion with a saline or crystalloid. Even patients with a history of heart failure that are not decompensated may benefit from volume expansion. Then we couple that with measuring filling pressures, whether it's LVEDP or right heart pressures, and that gives us an idea of where we are on that spectrum and how much more or less fluid do we need to give.
Yeah.
Exactly.
Yeah. Do you see utilization of physiology and imaging minimize contrast as well?
So absolutely. There's this push for zero contrast PCI. I think that may not be widely available to many people. It's a very tough thing to do when you're starting out. But there's a extension of that, which is judicious use of contrast and coupling imaging, FFR measurements, imaging with IVUS, dextran-based OCT with low contrast. So instead of being zero contrast, you can be ultra low or low contrast.
Yeah.
Typically defined as 1 times eGFR or less for a contrast dose.
Yeah. Who are the people who are at highest risk for contrast-induced nephropathy and from the patient coming to the cath lab?
So there's 2 sets of patients that are at the highest risk. The first are people who are presenting with STEMI or shock. The acuity of presentation is really a big determinant. The second is your baseline population of patients with chronic kidney disease, particularly stage 3B or 4 CKD, are at much higher risk of developing AKI. So it's really the patient factor plus their presentation.
Well, Anand, thank you so much
Absolutely.
for a wonderful, insightful information on the low contrast, as well as be very vigilant about CKD and AKI in the cath lab. Thanks for watching, and please watch these videos and others on the CVI YouTube channel. This is Chadi Alraies from Denver, Colorado. Anand, thanks so much.
Thank you.
Thank you.